Hello and welcome. Before we get started, I'd like us to just review the interpretation instructions. Bienvenue. Avant de commencer aujourd'hui, passons en revue les instructions d'interprétation. Okay. So I hope all of you were able to find your way to the French interpretation for those who speak French. I'd like to welcome you all to the second webinar in the PPH Community of Practice 3-day webinar series. My name is Jennifer Stevens. I'm the Principal Technical Advisor at JPIGO and a member of the PPH Community of Practice Secretariat. Please feel free to introduce yourselves in the chat box. Throughout the presentation today, please put any questions you may have in the Q&A box. We will review these at the Q&A session after the presentation. We do have just a brief disclaimer. The content you are about to see includes medically appropriate but graphic images. Viewer discretion is advised. The intention is not to offend, but to provide information to health practitioners and implementers. Proceed only if you are comfortable with the potentially sensitive topics. I would now like to welcome Andrew Weeks, our facilitator for today. Over to you, Andrew.
Thank you so much, Jen, and greetings to everybody from Liverpool in the UK. My name's Andrew Weeks. I'm Professor of International Maternal Health here in Liverpool and part of the steering committee for the PPH Community of Practice. So welcome to day 2 of our Placenta Accreta Spectrum webinar series. We're running them over 3 days. And yesterday we talked about epidemiology, pathology, and prevention. Today we're moving on to antenatal diagnosis. So how can you try and spot those, the placenta accretas which are coming up so that you can be well prepared for them? And then tomorrow, same time, same link, will be on placenta accreta management. And so how surgically do we go ahead to manage placenta accreta when it occurs, either when you've planned for it and when it occurs unexpectedly, as it sometimes does. But today we're going to talk about antenatal diagnosis, and we're very lucky to have Professor Sally Collins to speak to us today. Now, Sally's a professor of obstetrics at the University of Oxford, but also consultant obstetrician and lead for placenta accreta at Birmingham Women's Hospital, which is one of the biggest hospitals in the UK. She also chairs the International Society for Placenta Accreta Spectrum. She's had more than 14 years working both clinically and doing research in the field of PAS, and she's recognized worldwide for her expertise in this difficult condition. So over to you, Sally. Thank you very much. We're looking forward to hearing from you. And I'll switch off my camera now. Please take over.
Thank you so much, Andrew. I'm just going to share my screen and we will get started. So I've been asked today to talk about the diagnosis of placenta accreta spectrum. Now, for me, that is the ultrasound diagnosis. First thing first, conflicts of interest and disclaimers. As Andrew said, I'm the chair of ISPAS, lead author on their antepartum management guidelines, but I've also co-authored RCOG and FIGO guidelines. I'm an advisor to NHS England and an ambassador to Placenta Awareness UK, but I have absolutely no financial interests in the field of PAS. So the most important thing to say about PAS is that maternal mortality and morbidity is significantly decreased by antenatal diagnosis and management by an experienced MDT. Now, I've put 4 references here, but there's about 20 to 30 of these in the literature. Clinically, the bottom line is that when we open up and we see any of these, and these were all Accretas managed in our department, you want your theatre to look more like this than like this. And it is that antenatal diagnosis that makes such a difference to a woman's survival and also morbidity, particularly surgical morbidity, much less likely to have surgical issues if that woman is delivered electively by the right team at the right time in the right place. So how do we go about looking for PAS in the first place? Well, we get told that there's lots and lots of major risk factors. Previous cesarean, advanced maternal age, parity, assisted reproduction, previous PPH, multiple DNCs, a whole variety of risk factors. And people start to get very, very anxious about which women we should screen. The bottom line is the single greatest risk factor is previous cesarean delivery. We can just about forget the rest of them because the vast majority of the other risk factors lead to very mild PAS. They scar the inside of the uterus and just lead to a sticky placenta. What we're most worried about is those really difficult placentas that come as a result of a full thickness scar. So why are we particularly worried about a full thickness scar? Well, we know that when you've had one previous cesarean section and you have placenta previa, the incidence of PAS is 4%. But this rises exponentially. 2 previous sections, 10%, 3 previous sections, 40%. By the time you get to 4 or 5 previous sections, you're up to 60 to 70%. And there's a real toxic combination between having a PAS into a previous cesarean section scar, and that is the fact that you therefore have your abnormality, your pathology, very low in the uterus and therefore low in the pelvis, which makes it difficult to get to. It's completely in the way of delivering that baby, and consequently you have this really toxic combination. It's not that PAS per se is any worse than one arising in the upper segment from a myomectomy scar, for example. It's just that lower segment is thinner, it's deeper in the pelvis, and it gets in the way of delivering the baby. So as you can see, what we should be really, really worrying about and what we should be concentrating on in terms of our screening for PAS is previous cesarean delivery. So the one take-home message that I would ask you to consider is when looking at placental location at the mid-trimester anomaly scan, so that's the anomaly scan that happens between 18 and 20 weeks, or any other ultrasound scan that you might do, if your placenta is anterior and low-lying or previa, just ask that woman one single question. Have you had a cesarean delivery? If the answer to that is yes, then you really need to screen her for PAS. And the single best way of doing that is by referring them to an obstetrician who has experience of diagnosing PAS. So that's the message in terms of screening. What about diagnosis? I get told all sorts of things about diagnosis. What's the single best sign, Sally? What should I actually be doing, Sally? Well, I think we should stop thinking about things in terms of signs and ask for simple questions. The first question is, what is the pre-test probability of there actually being PAS in the first place? Now, you might be asking, why on earth am I interested in pre-test probability? Well, it comes as a result of this study by Phillips et al., which was published in 2019. They basically did a study of low-risk women who did not have PAS. All of their placentas spontaneously came out at delivery. But they gave the ultrasonographers pictures of PAS markers and said, report them if you see them. And absolutely astoundingly, at least 2 markers were seen in 98% of second trimester ultrasounds by sonographers when they were just looking for that marker. And the commonly seen ones were lacunae, subplacental hypervascularity, and an irregular bladder wall. And we have to really consider this, because this means that our current markers for PAS are very, very poor. And consequently, we have to really think hard about when we regard those markers as a marker for PAS, and when we just ignore them because placentas have lacunae. So if this woman has no risk factors for PAS, irrespective of whether her placenta looks a bit hypervascular or there's a few holes in it, she is extremely unlikely to have PAS. And you have to remember that if you're just looking at these markers in isolation, you will potentially see vague ones in normal placentas. The next comment goes back to our consideration of cesarean being the most important thing. If she does not have a full thickness scar, she will be highly unlikely to have severe PAS. Now, in old money, that used to be called increta or percreta. But these are the cases of PAS that kill women. They're the ones that have abnormal vasculature, massive neovascularity. The angiogenic factors have turned all of the pelvic tissue to really friable, distorted tissue. And these are the ones where we can potentially end up with a maternal mortality. So it is really important to remember, we use pretest probability in all other fields of medicine. For example, when we're assessing for deep vein thrombosis, you know, if your woman has a BMI of 54 and she's had a long haul flight and she's 36 weeks pregnant and she's got a family history, you know, if she comes in presenting a bit of a sore leg, you're far more likely to say your pretest probability is high that she has a DVT than a slim woman in the first trimester with no other risk factors. So it is just as important when we are diagnosing PAS. So we've established the importance of pretest probability. The next question we have to ask is PAS a binary condition? Yes, we've got it. No, we haven't. Well, absolutely not. The name points out it is a spectrum. And you have to think about it, it's very similar to, is ovarian cancer a binary condition? Well, yes, a woman either has ovarian cancer or she doesn't, but we would never consider just giving that diagnosis without thinking about where she is in terms of staging. So is this severe ovarian cancer with metastases all over her body? Or is it very, very early, caught within the ovary, and a nephrectomy is going to cure her? PAS is exactly the same. Yes, you can diagnose it as binary. She has PAS, she doesn't have PAS. But the really important thing to ask is, how bad is it? Is this just going to be a bit of sticky placenta, a focal FIGO grade 1? Or is this a grade 3C where we have placenta invaded into pelvic structures, turn them into the consistency of pate, massive neovascularity? Because they are very different, both in terms of how we diagnose them and how we manage them. So once we've thought about that PAS lies along this spectrum, we have to think about what we're looking at with ultrasound. Now, lots of people ask me, what's the single best ultrasound marker, Sally? And I have to say, there isn't one. And that's because when you look at all these placenta percretas at laparotomy, they all look completely different. If you can see this, they are absolutely all completely different. And yet they're all histologically percreta. So if they look completely different at laparotomy, how can there be a single ultrasound sign that makes the diagnosis? We need to stop thinking about diagnosing it in terms of signs and start thinking about diagnosing it in terms of the clinical features that that particular PAS is going to have. And therefore, that will tell us where it lies on the spectrum. So instead of thinking in terms of signs, let's think in terms of anatomy. Is there a vanishingly thin myometrium? If there is, we'll potentially get a placental bulge. Is there massive neovascularity that is going to cause us terrible trouble when we're trying to reflect the bladder? If there is, we will see hypervascularity and bridging vessels. Is there potentially invasion of other structures? Has any other structure been deviated? Has the line between two structures become very, very blurred? This is what we need to consider to give us an idea of the clinical features, to give us an idea of what we're going to find when we perform the laparotomy. Now, this takes me back to the study by Phillips et al. So if we're seeing massive false positives with the commonly seen features such as lacunae, hypervascularity, etc., what this really tells us is that the infrequently seen markers are the ones that are most specific to PAS. That includes placental bulge. Now that makes sense because that's reflecting a vanishingly thin myometrium. Bridging vessels, very thin myometrium, loss of clear zone. These are the ones that are specific to PAS. So, looking at signs, involvement of the myometrium. If you see a placental bulge, now you can see here on the right, the placental bulge is a deviation away from the normal line of the anterior wall into usually the back of the bladder, but it can also be into the broad ligament. This means that the muscular wall has lost its structural integrity. Now, that does not diagnose PAS per se, but the one thing it is telling you very, very clearly is this wall is affected by something and it will not be able to contract. So if it forms part of the placental bed, that part of the wall cannot contract to provide the living ligature to cut off the bleeding at the third stage. So even if you manage to get that placenta out, you may have a serious problem with bleeding afterwards. So this is a very important sign, and it is one that we think about in terms of the anatomy. And this is what it looks like when you open the abdomen at laparotomy. You can see in these three pictures on the left-hand side very clearly that we have an issue with that uterine wall. The upper segment has contracted down, but there is no signs of contractility within that placental bulge. And when I define placental bulge, you can see here with the yellow line, it effectively looks like seagull wings. It looks like how a child would draw a bird. There has to be this deviation, very sharp deviation from the line that you would be expecting the uterus to follow. And that demonstrates involvement of the myometrium. Occasionally, a deviation like this, a placental bulge, is as a result of a benign uterine dehiscence. Now, you can see this on the left-hand side. There's just a circle within the front of the uterus where the scar has given way and the placenta is underlying it. Now, importantly, it usually has very neat edges. The surrounding myometrium looks completely normal and it's potentially quite small on ultrasound, and the rest of the placenta itself looks normal. This is quite important because this placenta will separate from the surrounding uterus, and you can just sew up the defect that's currently being held together here by the serosa, or even a tiny thin little bit of scar that's left behind. So that's just important to remember, but it's much less common when you see a uterine, a placental bulge, that it's a benign dehiscence than a PAS. So looking at neovascularity, the neovascularity that comes with percreta causes a lot of the signs that we see. So interruption of the bladder line is very, very poorly interpreted. It's quite often taken as just seeing an irregularity in the bladder line, but that's not the case. We should be looking at these equal signs you can see up here in the top left-hand sign. Because interruption of the bladder line isn't actually the bladder line being affected, it's blood vessels. And it's those blood vessels that you can see here on the right at laparotomy, running within or on top of the serosa. And this interruption of the bladder line is due to hypervascularity. And it can also cause this scalloped look that you see on the left-hand side. This is an artifact as a result of your tangled mat of blood vessels on the serosa. It is being misinterpreted. People see a slightly irregular bladder line, which potentially comes from multiple cesarean sections and scarring of the uterus as it sticks back down to the front of the anterior wall of the uterus. And that is not the bladder line interruption that we should be looking for. Bridging vessels. Bridging vessels are absolutely marvellous to look for because they only occur when you've got this neovascularity on the front of the uterus. They appear to be bizarre vessels. You can see it here on the left-hand side that seem to be running from the placenta into the back of the bladder. Now, of course, blood vessels like that can't exist. What it is an artifact that is caused by taking a two-dimensional slice through the anterior aspect of a curved uterus. So you can see in the middle image here, coming out and taking a coronal view against the front of the uterus, what we're seeing is all these incredible blood vessels that we see on the front of the uterus and at the back of the bladder at laparotomy. So bridging vessels themselves are, I find, a very, very good way of knowing whether or not you're going to face severe neovascularity on the front of your uterus when you go in. Now, these blood vessels are really difficult to manage. The reason being they appear to have developed during pregnancy, and they have very little intima and no muscle wall. So consequently, if you try to ligate them, it's very easy for your suture to cheese wire through. And if you try to diathermy them with standard diathermy, it's very easy for the vessel to shear before it's fully coagulated. And that's what makes these blood vessels really difficult. And once you've damaged a few of them, you get incredible blood loss, which then takes out the view of your surgical field, and your hysterectomy suddenly becomes much more difficult. So it is important that you know that you're going to face these, because quite often they're behind the back of the bladder and you can't see them when you first open for your laparotomy. So this is a very important diagnostic sign. Loss of the clear zone. Again, this is often misinterpreted. The clear zone is a dark line that you see between the placenta and the myometrium. It's not anywhere else. It's not between the serosa and other organs, which I've heard people talk about. It's actually a dark line between the placenta and the serosa. Now, this is an interesting one because nobody really quite knows what generates this clear zone. And that has led to a lot of interest as to how can this hyperechoic region exist, because we know that there isn't a break between the placenta and the myometrium. Well, this set me thinking a little while ago, and I talked to a pile of ultrasound physicists. And Nitterbuck's layer, which is generated by a normal placenta, which consists of a fibrinoid layer that the placenta lays down 1/3 of the way into the myometrium, and is that silky smooth texture that you feel on the bottom of a delivered placenta. So Nitterbuck's layer is made of fibrinoid material. And I talked to the physicists and they said, oh, yes, fibrinoid material will probably come up as hyperechoic. And I thought, well, this is probably the clear zone then. And we know back in the old definitions of placenta accreta, Nitterbuck's-Lair played a fundamental role, and people believed it was absence of that should be a diagnostic criteria. And so this led us to wondering whether it is this lack of this fibrinoid material that stops the clear zone from being seen. And this led to us developing the separation sign. Now, the separation sign was, like I said, a crazy idea that we had here in Oxford. And we undertook a prospective study of 194 women who were all deemed to be at risk of PAS and were therefore referred to our clinic in Oxford. And we scanned them in the second or third trimester, and we assessed the placental separation at birth. The separation sign turned out to be an incredibly good sign to facilitate the ruling out of PAS. Now, this is hugely important because for me, I get sent women from all over the catchment area for me to scan and say, yes, I think they have PAS. No, I think they don't have PAS. And if I think they don't, I send them back to their unit. And if I'm wrong, I leave my colleagues at that unit in big trouble because they're the ones that will have to pick up the mess. So the important thing for me is actually being able to put my hand on my heart and have complete confidence that I am not sending them back a person who is not going to have a placenta that separates. And therefore, finding out that we had 100% normal separation in all the women that had positive separation signs led me to be very, very happy about this. So what I'm going to do is I'm going to talk you through the separation sign. It's a very simple sign that you generate by pressing the probe against the abdomen. And you can see here, this is a placenta. You press down on the probe, which obliterates the clear zone, and then you let go abruptly. And the myometrium pings back and you get this sort of little bounce. You can just see it at the tip of the yellow arrow where you get a little bounce where the clear zone suddenly there becomes more obvious before it disappears again. And this is because the elasticity of a placenta and the myometrium are very, very different. And the myometrium pings back into place and the placenta just bounces a bit, demonstrating the clear zone. I'll show you a negative separation sign. This was a placenta that was a Figo grade 1 and was stuck. You could see the myometrium there, but when you compress it down and you press the myometrium into the placenta, you can see here pressing down and you let go abruptly, the two just move as one. There is no bouncing apparent within the placenta. There is no opening up of the clear zone. I'll show you a positive one just one more time so you can see the difference. Pressing the two together, letting go, and the placenta there almost seems to bounce a bit away from the myometrium. And it's that little bit of the bounce, we almost called this the bounce sign, but actually we felt that was not very good, so the separation sign had it. But it is that little bounce, and if you see that, you know that Nitterbuck's-Lair is there and that placenta is going to separate. Obviously, importantly, it has to be throughout the whole placental bed. But if you've demonstrated it in the vast majority of the placental bed and there's no other signs, it is very likely that you can rule out PAS and you can send that woman back to her own unit with impunity. So this is just a quick plea. I get sent pictures from all over the world asking my opinion on PAS images, and they haven't filled the bladder. If you're looking at an anterior, low-lying or previa placenta and you're trying to assess for PAS, you must fill the bladder, otherwise you won't see any of the signs. So that was just a very quick trot through the diagnosis of PAS, but I am going to hammer home this take-home message. When you look at the 18 to 20 week anomaly scan, please document placental location. If that placenta is anterior, and low-lying or a previa placenta, ask one single question. Have you had a cesarean delivery? And if the answer is yes, you must have that placenta assessed by an obstetrician with experience. The other thing I'm just going to say is aimed at low to middle income countries. Number one, there is absolutely no need for MRI. Now, I know a lot of places use MRI as their diagnostic tool, and I'm asked about this at every single meeting I go to. What about MRI? What about MRI? Well, MRI is hugely expensive. You do get good pictures, but what matters is the eyes of the person looking at that MRI. How much experience do they have with placentas? How much experience do they have with placenta accreta? What happens in the UK is obstetricians who've got huge amounts of experience of looking at placentas send patients for an MRI in order to rule out accreta, and those images are examined by a radiologist who's never looked at a placenta in their life. So consequently, they're just not as good at it as obstetricians who've looked at lots of placentas. So if you don't have access to MRI, do not think that your diagnosis is going to be any worse than anyone else's. I can't remember the last time I sent anyone from an MRI, and I'm not too bad at diagnosing it. The other thing I would recommend is this paper. It's written by Theo Adebredu, who is an amazing sonographer from Ghana, and he has an awful lot of experience in placenta accreta. And he's written a guide, a very simple guide for ultrasound screening. And this was aimed at people who can scan, but who don't have a huge amount of experience. And it's a simple 3-step approach that's aimed at guiding sonographers with minimal experience through risk stratification, prenatal screening, both with and without Doppler ultrasound. And I would strongly recommend it. I hope that's been of help, and I'm very happy to take any questions. I'm just pointing out at the very bottom of my slide, we have a web page which is free, and it's Placenta Accreta Spectrum. That is actually the wrong address. There's 2 S's there. And it has lots and lots of images that hopefully you might find useful both for diagnosis and management. Thank you for your time.
Fantastic, Sally. Thank you so much. No, I've learned a lot from that. That's brilliant. So we have now an opportunity for questions. This is your time to put questions to Sally for discussion. Couple of ways you can do that. You'll see the question and answer box down at the bottom of your screen there. If you can click on Q&A, and there's already a couple of questions in there, then we can read them from there. Or else if you want to raise your hand, that's also fine. Put your hand up and then we can unmute you and go from there. Sally, can I pick up just a couple of things from your presentation, which I just wanted for my own interest, because I don't do this routinely antenatally. You talked about the placental bulge, and you showed a brilliant picture of the placenta bulging into the bladder. What happens if the area of accreta isn't behind the bladder? Do you see something similar if it's to sort of away from the bladder? Because the bladder gives us a lovely area, and I appreciate they're usually there, but if it's not behind the bladder, can you still see it?
Absolutely. The classic one is a bulge at the side that bulges into the broad ligament. Now, that is particularly difficult to manage because obviously you have your vascular bundle running down the side of the uterus, and that with it passing out into the broad ligament, it can make taking the uterine pedicle extremely difficult at cesarean hysterectomy. But yes, you can see the bulge anywhere. I delivered a lady who'd had a cornual ectopic, and she'd had the cornua of the uterus, she'd had the tube removed, and she'd had the cornua stitched up, and she'd been told not to get pregnant for 6 months. Unfortunately, she got pregnant the next month, and it of course implanted there, and the uterus literally looked like it had a Mickey Mouse ear, and it just bulged out into that upper cornua. So yes, you can see this placental bulge anywhere that you have damage to that myometrium.
Okay, brilliant. Thank you. The other question which I had, which actually one of the questions arrived in the Q&A about the separation sign, and well done for sort of picking that up, and it's, I guess it's a lesson for all of us. If you see something, well, do the correct study, and you can sort of prove it. And it's great that you've worked through that to show how effective it is. Getting my head around it, I'm assuming that it's refilling, because when you're compressing it with the probe, you're actually pushing the blood vessel. You're emptying the vessels from between the placenta and in the space, in the retroplacental space where all the villi are. You're sort of squeezing it and emptying the blood out of that area, and then you release it, and the blood rushes back into that area. Whereas with Accreta, you really lost that space. Have I got the
nobody knows what the clear zone is, but I don't think it's blood, because it runs all the way along the bottom of the placenta, and that would give us a pool of blood there. It's most likely to be the fibrinoid layer, because the spiral arteries go straight through into the intervillous space. And actually what you're doing is you're compressing the myometrium against the placenta, and you're just squashing the tissues down. The same thing can happen if you're using too much pressure on your ultrasound probe. You can obliterate the clear zone and get a false positive. So just to clarify, if you press down, and when you release, the myometrium springs back and the placenta does this little bounce and the clear zone appears, that is a positive separation sign, and it means that the placenta will positively separate. And that's how I try to think of it. So a positive separation sign, so you're seeing this bounce, you're seeing this just little appearance of the clear zone, and the placenta appearing to move separately to the myometrium. That means your placenta will separate. If the placenta and the myometrium are moving as one and there's no bounce between them, then it doesn't mean it won't separate, but it means that you absolutely shouldn't rule out there being PAS.
Okay. So it's always a difficulty with positive and negative, isn't it? So when you talk about positive separation sign, you mean that almost the two are moving independently. You push down on the myometrium and it bounces up, and the placenta bounces slightly, and that's
exactly that's positive. And that's the separation sign, is that exactly that the myometrium and the placenta are bouncing separately. They are two separate entities. The elastic myometrium and the liver-like texture of the placenta, which doesn't have the elasticity of the myometrium, which is why when you compress them and squash them down, they respond with different elasticities, and that gives you this myometrium bouncing back and then the placenta just slowly doing this sort of jiggle underneath. That is a positive separation sign. That means the placenta will separate. When the two of them are stuck together as if they were one, then they move together, and there is none of this giving way between the two of them. They just move as one, and that is a negative separation sign.
Okay, brilliant. Thank you. Can we move on to looking for the other ultrasound signs? Because that's a lovely sign which you see by pressing on it, and presumably it means it has to be anterior. You can't really get it if you've got a lateral accreta or posterior. It has to be on that front surface. And
you can sometimes sneak round laterally, but you can't do it in a posterior placenta.
So
however, sorry, I just need to say, my colleagues in Germany who do all of their accreta ultrasound transvaginally, you can use the separation sign with the transvaginal probe. You can press gently with the transvaginal probe and let go, and you will see it the same.
Yeah, I think a lot of us in the traditional world are pretty scared of doing anything vaginally with placenta previa, aren't we? But with it being gentle and with it, so long as you know exactly what you're doing, so that you don't disrupt the placental cervical lower segment interface, it's a very effective way of sorting out exactly where the placenta is. But I guess also then at the same time getting that sign of separation. Okay, brilliant. Can I ask you something else? And that relates really to the first question about Doppler, because quite a few of the pictures that you showed had Doppler on them. But that's not all that easy to interpret, and a number of the machines that people will have don't have Doppler. Can we still get good accuracy without Doppler? And clearly the separation sign is without Doppler, but what about the bridging vessels and the placental bulges and such like?
Absolutely. You can still get it without Doppler. There's good evidence that grayscale ultrasound in the hands of an expert has 90% accuracy. And that's because so many of the signs are the same. So, your bridging vessels you see with Doppler ultrasound, but they're represented by these equal signs that I showed you which is known as bladder wall interruption. So those equal signs are the blood vessels. So you can see that without color Doppler. Hypervascularity is the worst sign ever because it's so subjective. What is hypervascularity? So I would say don't turn your Doppler on for that anyway, because it's rubbish. Placental bulge is a grayscale diagnosis anyway. And so if you're looking, and lacunae, likewise, the most important thing about lacunae is there has to be lots of them. They have to be big and irregular, and they have to be connecting with the basal plate of the placenta. Placentas are temporary organs. They're the most amazing thing. We grow them in 9 months, we expel them, and we throw them away. It's hardly surprising that they often have holes in them. They're a temporary organ, and a normal placenta will have holes in it, and a normal placenta will have bobbles and black bits and all sorts of things. So that's why lacunae, when people are just thinking about it, am I seeing holes in the placenta, are a very poor marker. But if you're thinking, am I seeing holes in the placenta that's potentially coming from high flow blood vessels, which means they have to be connected to the myometrium, and they have to be big, they have to be irregular. It's about thinking about what it is you're seeing and what the underlying pathology is that will make your diagnosis more accurate.
So to summarize that, if you've got somebody with a previous section and a low-lying placenta, especially with 2 or more, then okay, you've got a very high pretest probability. In terms of adding grayscale ultrasound, that virtually sorts it. You can add Doppler, which may give a tweak of benefit. MRI really doesn't take you any further beyond that.
Yes, absolutely. Somebody who is thinking about it, who has a grayscale ultrasound, will be much, much better than a radiologist who's never looked at a placenta in their life, who has an MRI. And this is because you're starting at your baseline. Well, they've had 2 sections. Their a priori risk is 11%. Next thing, we're looking at a previa, and you haven't got a straight line at the front of the uterus. You've got this bulge. Okay, that's telling me there's a problem with the myometrium. On top of that, there's big holes in the placenta that are right underneath the bulge. Okay, that looks like lacunae. And I'm seeing equal signs all along the front of that bulge. That's telling me there's neovascularity. Now, you put all that together, you have a diagnosis of PAS before you've been anywhere near color Doppler. And you certainly don't need an MRI for that, because it's about thinking. Now, I think one of the participants has put in the Q&A, if the infrequently markers seen are most useful, does this imply that ultrasound has low sensitivity and specificity? Well, if the person who's doing the scanning isn't thinking about what it is they're seeing, isn't thinking about how is this relating to a possible diagnosis, then ultrasound does have low sensitivity and specificity. It has high sensitivity and specificity when we start putting together pre-test probability, the actual anatomy of what it is we're seeing. Then it suddenly all becomes clear.
But this has then got implications, Sally, hasn't it, for actually who does the ultrasounds? Now, I mean, there's always been a little bit of tension, shall we say, between the radiology department and the obstetricians as to who's the expert here, who does this, and I mean, maybe I'm biased, but is it fair to say that this is one specific condition where really you need to be looking with your clinical head on as well? And that really this is a particular area where even if you, I don't know, move prenatal diagnosis off to radiology, this is an area where it's the obstetricians because you need to put it all together. Is that right?
My feeling is the person who is in theatre when the belly is open is going to be the person who's going to be able to scan the best. So if you send me a whole pile of radiologists who come to theatre and who actually look at what we find at laparotomy and then go back to their darkened room, then they will become as good as the obstetricians. But at the moment, I think the obstetricians have to sit in the darkened room doing the scans, but they also have to go to theatre. The teams that do the best with PAS are the ones where the person making the diagnosis goes to theatre and follows up. They don't actually have to be doing the surgery because, there may be someone with a much, much better ability at surgery. I mean, certainly in our team, Human was the surgeon and I was the diagnostician, but we were both there in theatre. And for every woman that I imaged, I kept all the ultrasound. This is 14 years ago when I was trying to teach myself. I kept all the ultrasound images, and then I got intrapartum laparotomy images, and I went back and I thought about it. What is it I'm seeing on the ultrasound screen that we then encounter in theatre? And when we're in theatre, what is it Human's going to ask me? He's going to ask me specific questions. Does it go out into the broad ligament? That means I have to look round the sides of the uterus. Is there a bulge? He's going to ask me, how vascular is the cervix when I come to colpotomy, which means I go down and I look into the cervix and see if it lights up like a Christmas tree, because if it does, I'm going to say to him, colpotomy is going to be bloody because there's going to be vaginal and cervical varicosities. And what he's going to ask me is, it all looks benign, but when I start taking that bladder down, am I going to find a whole pile of blood vessels? And all of these things, I realized by going to theatre and seeing what the surgical problems were and then taking it back into the scan room and saying, right, I need to be able to say, are there bridging vessels behind the back of the bladder? Because that is tiger territory. Is there a bulge into the broad ligament? How vascular is the cervix? And then for the next woman, I would report on that. And I'd be able to say when we went into theatre, don't worry, the colpotomy isn't going to be bloody. However, it's bulging into the left broad ligament. So that is going to be a bit of a problem. And this is the thing, the person making the diagnosis, the person writing the report should be someone who goes to theatre and knows what the surgeon needs. So consequently, I am biased towards obstetricians doing this rather than radiologists, purely because I've never seen a radiologist in theatre.
Yeah. I mean, it neatly tells us, and just to remind people who have joined a bit late, that we're doing these series of 3 seminars, and tomorrow at exactly the same time, we'll move on to the surgical management with Eric Janiu, and so who will talk us through a lot of these ways of preparing and how, I guess, a diagnostician and the surgeon can act well together. But I guess that neatly, Sally, moves us into training because this is tricky. This is a new area. It's not classically taught. It's becoming incredibly important. And I think everyone who's a clinician out there fears these and will be very pleased that you've shown us the way forward today. But if you were going to a unit which had never previously done this before, or say if I was moving to a place which hadn't done, how would you suggest I go about training to get the system right so as to prevent these horrors?
Yeah. So I think the training has to be very similar to how we tackled it with my colleague in Ghana. So it initially started with Theo attending seminars like this, reading the papers, and looking at what the ultrasound signs were, how best to diagnose it. He then approached me in Oxford. So even though he was in Ghana and I was in Oxford, he approached me and said, if I come across difficult ones, would you be prepared to review my images? And I said, of course. And so he would send me static images and we would discuss them. And if it was too difficult with static images, which it can be, he would FaceTime me and show me the screen as he was scanning. And I could say left a bit, right a bit, up a bit, down a bit. Let's have a look at this, do the separation sign. And it didn't take very long at all before he was trained really, really well. He then had the abilities to pyramid this out and train other sonographers directly in Ghana. And this is how I think we have to start thinking about it. We need to get people who are interested, who get all the background knowledge they can, and then get a mentor or somebody who has experience with the condition. And we have to start really working hard to support each other to be able to pyramid out the training scheme. And, I think, as a result of this, Theo wrote the paper that I've shown you at the end on how to screen in low to middle income countries. And we just have to acknowledge that telemedicine and telehealth, which can be as simple as a smartphone on FaceTime, on the WhatsApp application, showing somebody else what you're seeing, is a way of training. And we have to share the knowledge. We have to share the knowledge nationally. We have to share the knowledge internationally. And this it can be incredibly successful. I was telling you earlier, my colleague Alvaro in Colombia does a lot of focal resection, conservative uterine surgery. And he managed to introduce that to Ghana via Theo because they had Alvaro looking at a smartphone in Colombia, guiding the surgeons in Ghana through their operation, and that enabled that team to do their first conservative uterine surgery. So telemedicine, collaborative work is the way forward, and it's certainly the way that we can train people.
Well, I think there's training the trainers, and if every country, I mean, I don't know how many countries are represented in the 120 people here, but if each country has a lead on it, or a group of people who lead on it, they can start to do that training. And so, because setting up referral systems is also not easy, is it? People you want to hold on to your own cases, but this is a situation where if you've got somebody with 2 previous sections and a low-lying placenta, really we shouldn't be unless we're trained. But equally, we need to make sure that the person at the referral centre is trained as well, because so actually it's a whole system thing, really, isn't it?
Absolutely. And the problem that we see is if people aren't adequately trained, we get a very, very high false positive rate, which leads to harm and unnecessary hysterectomy. There's one quick question. Should we scan for placentas for all previous deliveries, even without previa? Absolutely no. If your placenta has to be implanted in that niche, so it needs to be anterior low-lying or placenta previa. If your placenta is away from the anterior lower segment, then it's very, very unlikely that they will have accreta into that previous cesarean scar.
Brilliant. Thank you so much, Sally. So I can see that Jen's joined, which is a sign that we're getting near the end of the hour. So essentially, what we've learned is that antenatal diagnosis of placenta accreta, improves outcomes, it improves mortality and morbidity if we can get it right. The single greatest factor is previous cesarean sections, and it rises from just, what, 4% up until 60 to 70% if you've had 4 previous cesarean sections. So that needs to be at the front of our heads, but you need that plus a low-lying placenta. And if you've got those two things, a previous section and low-lying placenta, you need to get referred. And that should be at the front of your mind when you're doing scanning as well, because many of the features that we see are present in normal, healthy individuals. And the referral centres won't thank you if we start scanning everybody and sending everybody with a lacunae or signs of neovascularization to them. There's no single marker on ultrasound, but the separation sign is a very good one. But look for a combination of markers along with the relevant history. So thank you so much, Sally. We'll move on tomorrow onto exactly what we do when we go on to surgery. But for now, I'll hand back to Jen.
Thank you so much. I just want to take a moment to thank Andrew Weeks, who has been our facilitator today, and Sally Collins, our presenter. It was just a wonderful, wonderful presentation for me. I really enjoyed it. Thank you. I also want to thank our interpreters and our whole team. We look forward to seeing all of you tomorrow at our final day 3 in our 3-day webinar series focused on placenta accreta syndrome and also management of placenta accreta. We'll be reviewing as well as placental retention. That's going to be our focus tomorrow. So a lot more about surgical response and surgical techniques for management of PAS. Remember, we will use the same link that you used for the webinar today for tomorrow's link. So we hope to see you all then. Thank you so very much.
I think if anyone wants to join the PPH community of practice, or you know of others who do, have we got the QR code?
Coming right up.
It's there in the.
And we'll be also reviewing it on the 3rd day as well. We'll be going over PPH community practice. So
Brilliant.
please join. Yes.